You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for May 19th, 2023. This week, when to use an ICD, hypertrophic cardiomyopathy in 2023, blending electrophysiology and structural in post-TAVI patients, and high-sensitivity troponins. First topic is the ICD in patients with non-ischemic cardiomyopathy. Now, modern times has brought renewed interest in risk stratification for the ICD. But first, let me digress a bit on ICDs. In the old days, cardiologists had simple rules for implanting an ICD. If the ejection fraction was less than 30 to 35%, a patient with heart failure on medical therapy, you recommended an ICD because trials showed that this improved survival. Not cardiovascular death, overall survival. Of course, this rule also included making sure the patient had reasonable expectations of good survival time, quality of life, and that there should be a thorough discussion about the benefits, harms, and expectations. Sadly, during the period of irrational exuberance of ICD implantation, this was the time right after Scud-Heft and Made It 2, ICDs were overused, fueled by brilliant marketing and keen use of key opinion leaders. Ejection fraction less than 30% morphed into, you need this ICD. Well, progress has made ICD decision-making harder, a lot harder. In 2017, heart failure trialists published a pretty undercited paper that showed a robust decline in the rate of sudden death in patients with heart failure over the 20 years of heart failure trials. I will link to this paper, which concluded, quote, the cumulative incidence of sudden death at 90 days after randomization was 2.4% in the earliest heart failure trial and 1.0% in the most recent trial. Now, that's a hugely important trend for ICD use, right? ICDs can only improve survival if VTVF is a large proportion of the deaths. Now, around the same time as that paper in New England, Lars Kohlberg and colleagues reported the results of the Danish trial. This was an RCT of ICD implantation in patients with non-ischemic cardiomyopathy, terrible ejection fractions, but really good background therapy. And in Danish, the Kaplan-Meier curves were nearly identical, no difference, none. ICDs in a modern setting did not reduce mortality. Now, Danish is highly inconvenient for the EP and device industry, so it is largely ignored. Guidelines still include ICD implantation in patients with non-ischemic cardiomyopathy. Now, one trick that proponents use to ignore Danish is to meta-analyze it with older trials and say, look, in meta-analyses, ICDs are still beneficial. Now, this is a pro tip for any young listeners. Always be cautious of meta-analyses that include old and new trials. Now, here's a new modern problem, though, and it's not so simple as ICDs work or ICDs don't work in non-ischemic cardiomyopathy. Here is the problem. Here is why. In the days of old, the term non-ischemic cardiomyopathy simply meant patients without an infarct-related cardiomyopathy. Non-ischemic cardiomyopathy in the modern era is a much, much more diverse group, right? You have sarcoid and amyloid and healed scar from myocarditis and hypertrophic cardiomyopathy and ARVC and non-compaction and genetic forms such as familial dilated cardiomyopathy related to lamin AC mutations. We have so far advanced beyond the simple distinction of non-ischemic cardiomyopathy. And within this vast, diverse group of patients, there are going to be gradients of risk, sudden death risk. And sit down for this. Some of these patients with cardiomyopathy, not due to old myocardial infarctions, will die of sudden death and have ejection fraction greater than 35%. Now, we have known for decades that ejection fraction is an imperfect risk stratifier. Yet, in the old days, there was very little interest in risk stratification beyond EF. You know why? Because it risked decreasing the number of people who would get ICDs. Modern times have brought renewed interest in risk stratification, and this group at Rochester, New York, home of the MADE-IT trials, has presented a paper on a simple risk score for predicting VT-VF and non-ischemic cardiomyopathy. And wouldn't that be awesome to have a CHA2DS2-VASc score for non-ischemic cardiomyopathy? Journalist Robert Fulton has coverage on the heart.org Medscape Cardiology site. The first author of this paper, Ido Goldenberg, presented the findings at the American College of Physicians meeting. They had data on about 1,500 patients that they took from MADE-IT and MADE-CRT trials. These are all patients with non-ischemic cardiomyopathy. And through the usual statistical methods, using patient characteristics and outcomes, they came up with 3 risk groups: high, low, and intermediate risk. The main risk factors that they used to make these risk groups were ICD versus CRTD, left ventricular ejection fraction less than 25%, male sex, and black race. Now, how good was this simple score? The 5-year cumulative incidence of VT were 15%, 24%, and 42% respectively, depending on low, intermediate, and high risk. The burden of VT in the high risk and intermediate groups was significantly higher when compared to the low risk group. The C index of the model, though, in the development cohort and in the external validation cohort was 0.71 and 0.69 respectively. Okay, my comments. Before I say anything about efforts like this, I want to say we should absolutely have more work done in risk stratification. We should have had this 20 years ago, but no, we settled on ejection fraction, which is like treating all sore throats with antibiotics, even though only a fraction will have strep throat. Of course, the best way to study risk stratification is with an RCT. You pick a group that you think would benefit more from an ICD and you randomize that group. For instance, I wonder what a trial of women only would have shown. Women have a lower risk of sudden death and a higher rate of complications from an ICD. This would have been an interesting trial. But this wasn't done. Why? Because it might have decreased the number of people who got ICDs. I'm afraid that this risk score is not going to be good enough. Low-risk patients in this study still had a 15% risk of significant ventricular arrhythmias, and that's not good enough, especially when you are considering younger patients. The C statistics suggest the risk score is slightly better than a coin toss. Now, the excitement of the day now, though, I want to mention is the use of imaging to risk stratify patients for an ICD. I will cite a paper in which an Australian group has looked at ICD implants in Victoria and found a strong association between ICD implantation and reduced all-cause mortality and CV mortality only in those patients with non-ischemic cardiomyopathy who have LV scar. Actually, I'll also cite, and I found this, that there's going to be a trial in the UK called British, which will test ICD implant versus no implant in patients with CMR-based scar. Now, scar on CMR might identify a group that benefits, but of course the major headwind in this space is always going to be the good background therapy. And of course, in older people, the headwind will be competing causes of death. Now, another potential risk stratifier for an ICD is genetics. It's early yet, but already there are gene markers such as lamin AC mutations that confer a high enough risk that an ICD might extend survival. Now, I think there are a few better areas in cardiology, like that ICD use, that underscores the fact that evidence often has an expiration date, right? ICDs were highly beneficial 20 years ago, but the question remains, will they be as beneficial now, given the temporal changes in cardiology? All right, next topic, screening in patients with hypertrophic cardiomyopathy. My colleague, Brazilian electrophysiologist, Dr. Bruno Valdegem, has a nice recap of the TEMPO HCM study, which was presented at the ERA meeting, European Heart Rhythm meeting. This study raises a bunch of good questions. Okay, Spanish investigators, first author Juan Caro Cardon, studied the issue of screening patients with hypertrophic cardiomyopathy for both AFib and non-sustained VT, primarily non-sustained VT. Now, non-sustained VT is especially important to discover in these patients as it is one of the strongest risk predictors for sudden cardiac death. Detecting AFib is also important because of the increased risk of clots and stroke. Now, there are always going to be very few RCTs in the hypertrophic cardiomyopathy space because HCM is uncommon, right? Through modern imaging and perhaps ECG screening, we're seeing more HCM, but still, HCM is fairly uncommon. One of the main jobs of the doctor caring for the patient with HCM is risk stratification. Until recently, we have used a 24-hour, maybe a 48-hour ECG monitor to look for VT. Yet both AFib and non-sustained VT are fairly infrequent arrhythmias. A 24-hour look might miss it. So the idea of the Spanish team was to look at the impact of longer-term monitoring for these arrhythmias. This was a prospective registry-type study at 5 centers. Patients with HCM had 30-day monitors. Guess what happened when you look longer? Well, it was sort of mixed. For AFib, in the first 24 hours of monitoring, only 6% of the 100 patients who had HCM had AFib detected, and after 30 days, that 6% only went to 10%. For non-sustained VT, it was very different. Longer monitoring made a big jump. 8% had VT detected in the first 24 hours. But after a 30-day monitor, it went to 62%. So 8% to 62%, that's a big difference. Now, when they looked at the time course of detecting non-sustained VT over that month, there seemed to be a plateau. There was a steep rate of detection from days 0 to 15, so 2 weeks, but from 2 to 4 weeks, the rate of detection seemed to flatten out. The authors then made a very interesting leap. They took the increase in non-sustained VT and applied the current risk stratification parameters and found that 22%, 1 in 5 patients, were potentially reclassified in a higher risk category. And if you use the European model, 14% more patients would be in the may consider ICD criteria, and 8% would be in the ICD should be considered criteria. Now, my comments. I missed this study when it came out, so I want to thank Bruno. Please do read his column. He asked some great questions, especially at the end. You might think, come on, Mandrola, of course you will detect more arrhythmia if you monitor longer. Why is this a big deal? Well, here is why. This study and its results represents a microcosm of the new challenges that we face. A 30-day monitor is one thing. Well, what about digital watches, ILR recorders that are always on for years? I am sure any clinician listening to this knows that more monitoring means picking up more arrhythmias. The problem comes in translating this to the patient. AF is a great example. The benefits of oral anticoagulation were established when all we had were symptoms and a 12-lead ECG in a doctor's office. Now, we pick up AFib so much easier, and we don't know that the benefits of oral anticoagulation apply to AF episodes detected with constant monitoring. In fact, it probably doesn't, as the NOAA AF study of DOAC for subclinical short-duration AFib has been stopped for futility, and I'll link to that press release. So I want to gently push back on the authors here that use the data with longer monitoring to reclassify patients to higher risk. Why? Because the thresholds for non-sustained VT and VT risk in hypertrophic cardiomyopathy were established with a lot less monitoring. Now that we monitor longer, maybe we need new parameters for risk prediction. Is VT detected on a 1-day monitor the same as non-sustained VT detected on a 30-day monitor? I wonder. I doubt it is, but we need more data. And it makes me think, and hopefully you too, about the challenges of translating all of this digital data that we get. Now, the makers of digital devices aren't motivated to correlate data with outcomes. Their selling points are, hey, look at all this data we can collect. And I've scrolled through health apps in the clinic on patients, And it's shocking to what people see on their phones. Data upon data upon data. Yet many of these patients have all this data but ignore their expanding bellies or their inability to touch their toes. Sometimes we find good things with all this extra monitoring, but I strongly believe we need new normal values. Having or not having non-sustained VT in the presence of hypertrophic cardiomyopathy surely means different things when the monitor is 1 day versus 30 days versus 3 years of monitoring. Okay, next topic is fun. I enjoyed this one. It's blending electrophysiology and structural together after TAVI. Skeptical as I am, I believe TAVI has been or is one of the great achievements of modern cardiology. Patients with severe AS are some of the sickest, most symptomatic people we see. They are asking for and need our help. It is as pure as medicine gets. It's about the exact opposite of screening healthy people. Yet the established treatment, surgical AVR, is no small thing. Many older high-risk patients sick from AS, not with AS, could benefit a lot from TAVI. If we use TAVI in the oldest and sickest patients, the higher pacemaker rate after TAVI would be no issue. But cardiologists and patients are seeking less invasive ways to replace stenotic aortic valves in all patients. And the natural thing, therefore, is to extend TAVI to less sick patients. And iterative improvements in the valve and implant procedure make this more feasible approach. But there are headwinds. There are always headwinds. And one of the stiffest headwinds to squishing the bad valve and inserting a new valve is that the conduction system lies adjacent to the aortic valve. All aortic valve replacements can lead to heart block and the need for pacemaker, but rates of pacer implants after TAVI remain higher than after surgical AVR. The journal JACC Interventions published an observational study from a large group of Italian investigators, first author Francesco Bruno, in which they used registry data to study the association between the percentage of RV pacing and adverse outcomes in patients who had pacemakers after TAVI. PACE-TAVI is an international, many-center registry of consecutive TAVI patients who had pacers after TAVI. Now, for this non-random comparison, the authors divided the 377 patients into those who had RV pacing less than 40% versus those who had RV pacing more than 40%. Their endpoint of interest was a composite of CV death or heart failure hospitalizations, and of those 377 patients, about half the patients had V pacing less than 40% and V pacing greater than 40%. The authors then did statistical adjustments and found that the risk of the composite endpoint of CV death and heart failure hospitalizations was 2.76-fold higher in the high percentage pacing group. And taken individually, both CV death and heart failure hospitalization tracked significantly higher in the patients who had high percentage of RV pacing. All-cause death was also 2x higher in the high pacing group, but that did not reach statistical significance because of wide confidence intervals. Patients with V pacing greater than 40% showed a higher New York Heart Association functional class and a non-significant reduction of LVEF on 1-year echoes, while patients with V pacing less than 40% showed significant improvement of the EF. So the authors concluded that in patients who have pacemakers and use them a lot to pace in the RV after TAVI, outcomes are worse. Quote, "These findings suggest the opportunity to minimize right ventricular pacing through dedicated algorithms in post-TAVR patients without complete AV block, and to evaluate a more physiological ventricular pacing modality in patients with complete AV block." Now, I like this paper. Yes, of course, it is observational, and there will be confounders. Patients who need more RV pacing may be inherently sicker, and that is why they did worse. But let's put on our Bayesian hats for a second. Let's think about priors. We know from oodles of studies, both randomized controlled trials, remember, MADE-IT-2 had a signal of more heart failure in the ICD arm likely because of RV pacing. And we have lots of observational studies that show that RV pacing increases the risk of pacing-induced cardiomyopathy. The incidence of pacing-induced cardiomyopathy ranges from 10 to 25%. So our prior knowledge suggests that RV pacing is detrimental. And that too makes sense. It is consistent with bioplausible mechanisms. An RV-paced beat is clearly better than no beat, but pacing the RV muscle creates a right to left contractile dysynchrony. That's because RV contraction after a pace beat occurs first, and then LV contraction. An RV-paced beat is similar to a beat with a left bundle branch block, right? In left bundle, the RV is activated way before the LV, just like it is in RV pacing. Now, the solution to this problem is pretty simple and very exciting. Electrophysiologist teams should strongly consider conduction system pacing in these patients. I am near 100% left bundle branch area pacing. Here is what happens when you do that. When you place a lead into the septum, you can actually, if you get it through the septum enough, capture parts of the left bundle. This leads to a QRS morphology that looks like a right bundle. And most importantly, if you do that, LV activation is not delayed. Normal left to right activation is preserved. There's no dysynchrony with these beats. And there's another advantage of conduction system pacing beyond dysynchrony. When you pace the ventricles without creating left to right dysynchrony, you don't have to extend the PR interval. Conduction system pacing allows for a normal PR interval, and having normal AV north-south synchrony, I think, is very much underrated. In our hospital, nearly 100% of post-TAVI heart block patients are treated with left bundle branch area pacers. I strongly suspect this is going to prove beneficial, and it's another reason why I think TAVI done at expert centers who have experienced EP docs may have better outcomes. Now, I hope I've stirred you all up. Here I am promoting an unproven, untested pacing technique. Mandrola, where is your data? Perhaps you are enthralled, entranced by these beautiful ECGs from conduction system pacing. Well, there is some data. There's a small trial, non-random comparisons. But here at HRS, we are having our first investigator meeting for the left versus left trial of conduction system pacing versus CRT. It's going to be a big multi-center overall survival trial. Of course, it's going to be with government, not industry funding. Stay tuned, but I will bet you all a big cappuccino that left bundle branch area pacing proves superior to RV apical pacing. All right, final topic today is troponin assays. Don't laugh, but our hospital has just recently started using high-sensitivity troponin, and it's creating a bit of confusion. I'm going to try and sort all this out. Jack has published a study that sought answers as to how to define a normal high-sensitivity troponin value. It turns out it's not so easy. John McAvoy and colleagues led the analysis of using frozen blood samples from individuals in the NHANES studies. NHANES is a longitudinal study from 1999 to 2004. They measured the 99th percentile upper limit of normal. Henceforth, I'll just say upper limit of normal for 3 high-sensitivity troponin I assays and 1 high-sensitivity troponin T assays. They had about 12,000 individuals in the sample. Now, the first task was to find super healthy control patients. And to do that, they excluded people who said they had cardiovascular disease, or who had abnormal BMIs, or those taking cardiovascular meds, or those with diabetes, hypertension, high cholesterol, smoking, heavy drinkers, those with recent admissions, and those with high BNP. That left about 2,700 people who formed the healthy reference subsample. Now, the other 10,000 or so formed a second group, those without overt cardiovascular disease, but some risk for cardiovascular disease. You know, these are the type of people who usually present with chest pain syndromes. Then they compared the upper limits of normal for each troponin assay in these adults. Importantly, they also reported high-sensitivity troponin percentages by age, by sex, and by race and ethnicity. Their first finding was that in the healthy cohort, the upper limit normal for all 3 troponin I assays were lower than the manufacturer reported upper limit of normal. And in 2 cases, the upper limit was less than 1/2 of the approved cutoffs. Now, the upper limit for the troponin T were consistent with what the manufacturer said. Second finding, healthy men had higher upper limits of normals than healthy women across assays. Finding number 3, older individuals showed higher upper limit of normal values than younger, and all were statistically significant. Finding number 4, they found no significant differences were observed when stratified by race or ethnicity. And the fifth finding, in the general population without heart disease, but with risk factors, for example, the other 10,700 individuals, the nationally representative upper limit of normal for high-sensitivity troponins were higher than the 99th percentile upper limits calculated in the healthy reference sample, and there were those same age and sex differences. Okay, my comments. Please be not afraid. This all seems super confusing, but I'm going to try and make it very simple. First, let's just say there's some flux in the exact choices of upper limits of normal. Some of this uncertainty includes different assays, age, sex, but not importantly, race and ethnicity. These are good things to know. But clinically, I don't think much has changed, even though greater sensitivity of this assay has made troponin assays much less specific. Now, one great thing is that in low-risk patients, those with a very low likelihood presentation, 2 normal high-sensitivity troponins have incredibly strong negative predictive value. Now, but don't let these details on this little bit of flux in the upper limits of normals intimidate you. The first and most important question you have to answer when seeing patients in the emergency department or clinic, is this an acute coronary syndrome from acute occlusion, either a STEMI or non-STEMI? Now, you make this mostly on clinical grounds. You look at the chest pain history and the ECG, and the troponins are barely needed for this. If there is a plaque rupture type MI, then the treatment pathway is clear. STEMIs go to the lab, non-STEMIs get antithrombotic therapy and also to the lab in most cases. When plaque rupture isn't suspected, clinicians ought not to do troponins. This includes patients with SVT or acute AFib or pneumonia. But even when there are troponin elevations, the treatment is to treat the underlying cause. Treat the underlying cause. This includes troponin elevations from type 2 MIs from demand ischemia, seen in cases of anemia or tachycardia. And it also includes acute or chronic myocardial injury, say from acute myocarditis or CKD, or even super strenuous exercise. Clinicians need not worry too much about the exact upper limit of normal because we have to use a lot more than just a biomarker. Again, may I repeat, in the absence of a plaque rupture ACS, don't do troponins. And if there are troponins, don't be tempted to go to the lab. Treat the underlying cause when there is no ACS. Now, in case you are interested, Andrew Foy and I wrote this explanation out in JAMA Internal Medicine in 2021, and I will link to that short article, and we put a table in there that I hope is useful. So that's it for this week in cardiology. As always, I'm grateful that you listened. And remember, my friends, if you like this podcast, please consider giving us a rating, writing us a review, as these things help others find us. This week, I'm recording from New Orleans. I'm at HRS, and so next week on the podcast, I should have some good studies to talk about here at HRS. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.